Good afternoon, ladies and gentlemen. So we have a great panel of speakers, internationally well respected, that we're absolutely delighted to join our symposium. And our symposium is around tough on biofilm, gentle on the patient, when hard to heal wounds require more than silver. And I think as clinicians we recognise the burden and costs of chronic wounds have long been recognised. And we know the link between biofilm and wound chronicity is also well documented. But despite this evidence, are we still waiting too long before engaging in the battle against biofilm? So I'd like to put this question to our panel, and throughout their presentations hopefully we can offer you some supporting information to answer that question for yourselves.
When I got into biofilm back in 2003, this thing on the top, the contamination infection continuum, that was the prevailing theory of the day, and you'll still see it today. When we started looking down at the wound bed, we didn't see that. I don't think that exists. I think that's just a concept. What we saw was the bacteria would attach, it would form microcolonies. There would be an accumulation of signaling molecules, quorum sensing. It would form a mature biofilm, and it would control the wound bed. Okay, so biofilm was there. And you notice we kept a continuum because we knew in 2003 that it takes 30 days, it takes 60 days, it takes a long time for a chronic infection to start. That's why everybody says, it's got to be here this length of time before we can call that a chronic wound. Well, fast forward 2 years, and Masako came out with an article. It's a benchtop article, but it's using human components. And what he showed was that the bacteria decided quite quickly which path it was going to take. Is it going to be planktonic, try to cause an acute infection, or is it going to be biofilm? So it's attaching within 5 minutes. And so it's decided to go a biofilm route. It's forming that microcolony within 30 minutes, not 30 days. 30 minutes, and it's a mature biofilm within 24 hours. Okay, so what do you do with that? So the paradigm shift, this epiphany for me was, oh, this doesn't take a lot of time. Okay, this happens quite quickly. Well, it was proved up even more by an article by Del Pozo and Patel. And what they showed was that these are chronic infections associated with biofilm. So we're not alone in the chronic infection world, and we can learn a lot from the others. But the supporting references that they give, when you read those, you find that chronic sinus infections very often start acutely, and then they persist for weeks, months, and years. Okay? Infected hardware often comes out before 30 days. Well, that blows up your 30-day window for chronic, okay, because we know that's a biofilm infection. And many of these other clinical chronic infections happen acutely. So all of a sudden we're starting to see that we don't have this time mandate for the development of a chronic wound. What makes it chronic is its persistence in the host environment. Well, let's go down to the molecular level. Kim was tasked by cell host and microbe to make sense out of what the scientists were seeing. In panel A, the scientists would use E. coli, and that E. coli in their experimental design would go in, it would invade the cell, it would kill the cell, it would upregulate its own proteases, it would digest it, and it would propagate. And you and I would see that as an acute infection. So think strep throat, cellulitis, an acute thing that would raise our white count, give us a fever, and so that's an acute infection. That's great. Everybody knew that that's how bacteria infected. However, they were finding more and more in certain experiments that the bacteria would attach to the surface of the host cell. It would prevent the host cell from dying by injecting small molecules into it. It would take over the cytoskeleton so it can't migrate or shed, and it would form that pedestal formation you see in panel B. So what Kim concluded from this was, hey, we've got a new paradigm on how bacteria infect host cells. Well, but it's not, because we've been dealing with chronic infections, I mean, as clinicians, wounds and other chronic infections from the beginning of time. And so we know that an acute infection is quite different from a chronic infection. So what you're seeing in these two panels is a molecular definition for what an acute infection is, and in panel B, what a chronic infection is. I don't trust artist renditions, so I like this this electron photomicrograph that shows that there's bacteria that's attached. So if it's attached, it's biofilm phenotype, not disputable. And then you see the pedestal formation. So it has compromised or commandeered or done something negative to that cell. Basic definition of an infection. That, in its basic, most truest sense, is a biofilm infection. And so you're seeing that in real time. Okay, so that's a real thing. Just hammer this time concept home. This came out in January. And if you look at the timeline, you can see attachment in 40 seconds, and there you go, 40 minutes for attachment, microcolony, and stuff like that. This is extremely rapid. The 15 years of intervention from Masako to this has been proved up very definitely. So biofilm infections can happen in a very brief period of time. Let's go to animal models. This is out of northwestern Musto and Galliano. And what they're trying to show in this panel of slides is that slough will reaccumulate. So when you debride on the left side, you leave little fragments of biofilm, and then that biofilm reconstitutes itself. And that's in 24 hours. The reason I'm showing that so you can see the rabbit ear model, but then also whether it's a rabbit ear, whether it's a mouse, whether it's a pig, to cause a wound that has exudate, slough, non-healing, you have to seed it with bacteria. So in all our animal models, you have to have bacteria to make that behave like we see a chronic wound behave. The other pushback we get is, well, can biofilm impair healing? Well, when those guys in that rabbit ear model looked at a number of different bacterial species for their biofilm, what they found is the independent variable that was clinically or statistically significant in preventing the healing of wounds was biofilm. Okay, so yes, biofilm impairs healing. We know the molecular mechanisms of it. We know how that happens, okay? And the p-value is 0.001. I mean, it's not, biofilm does impair a host healing of wounds or defects. Well, the science is there. It was reviewed by the European Infectious Disease Society. I love to use them as my experts, okay? And they came out with this supplement in 2015. And it's very simple. Their article starts off, biofilms cause chronic infections. Okay, it's that simple. I think the science is settled. I'm going to try to show you a little bit more. But this is the brightest and the best across Europe, and they say biofilms cause chronic infections. That's great, but for us, in chronic infection, they chose to illustrate this with, and lots of references, if you want to go grab that, is the chronic wound. So for them, chronic wounds are chronic infections. Well, for something to cause something, it's got to be there. So in our early work, we saw biofilms in about 60% of our wounds. And on the right side, you see the other, that's an acute wound. We didn't see biofilm in those, okay, about 16 of those. The biofilm on the left, it's coccygean rods, and it's big and it's little, so it's polymicrobial. You can see it's stuck to the host surface. And what you're looking at is a real chronic wound bed, and that's really present on the surface of those wound beds. Sometimes it's like Omaha Beach. It's so degraded you cannot see what's happening. But with newer methods and newer techniques, I think Matt Malone's article says 78% of chronic wounds have biofilm. I think it's going to be higher than that, and here's the reason I think that. So on the right, you see an acute wound. It's got buds. It's not senescent. It has no accumulation of material. For that accumulation of material you're seeing in the video, something has to attach to the surface. It has to inflame the wound and cause that persistent inflammatory response, elevated pro-inflammatory cytokines and MMPs. you notice that the slough is different from person to person. It's watery or it's waxy, and that's the complexity that the different species of bacteria that get together to form that biofilm. But the biofilm has to inflame, it has to cause that plasma to leak out to feed itself, and then it has to cause a senescent wound bed, or else it will be released to the environment. So when you see accumulation of material, when you see exudate, accumulation of material, senescence, non-healing wound, those are all behaviors that we associate with chronic wound, and they're all directly related to the properties and the abilities of a biofilm to cause infection. So just to bring it all home on that point, we use Koch's postulates, and this was an eye-opener for me. It was just really good to see. I would harvest the slough off a human wound, take it over to the lab. We'd get a mouse out, anesthetize it, cut a little patch on its back, seed it with the slough, and and then cover it with tegaderm, and then we would watch it day to day. By day 1, we'd see exudate. By day 2, we'd see slough. By day 4, there's slough, and it's bulging, and the wound is not healing, that impaired healing that we saw in the rabbit ear model. Okay, so it's causing a chronic wound. I saw that develop by my own eyes over 2 or 3 days, and that was a cool experience to see. And so at the end of 4 days, we have that. But then when we pulled that bacteria off and we sequenced it, it was the same bacteria that we pulled off the human wound. The biofilm had come across as a unit and caused that chronic infection in that mouse, and then we were able to recover it, fulfilling Koch's postulate, saying that the cause of that chronic wound was indeed the biofilm. So let's go back to the European infectious disease guys, and they're saying there's clinical evidence, clinical things that you can look at and say that's probably a chronic infection. Well, they're ID guys, so they're worried about antibiotics, but we're worried about wound behavior. So when you see that exudate, slough, senescence, non-healing wound, you know you have a biofilm. You don't need the microscopy or other things to define that. You do need molecular methods to tell you what bacteria are causing that chronic infection. You know it's biofilm, but you need to know what the species are so you can treat it specifically. We use PCR sequencing methods. Clinical cultures are just deficient. Biofilms are viable but not culturable, and they're polymicrobial, which really limits clinical cultures in the area of chronic infections. What the European Infectious Disease Society's wish list included was that we would combine, we'd weave our therapies together, that we could degrade the biofilm defenses and then deliver cidal agents to the bacteria, the constituents that make up the biofilm. And that's going to be, I'll illustrate that in the step-down therapy on the last slide. So let's bring this home, land it. Okay, so we mainly treat chronic wounds by trial and error. We try this therapy. If it doesn't work after 2 weeks, we try that therapy. So it's single therapies strung together, absolutely the wrong strategy for biofilm. Biofilm requires multiple things done at the same time: control, collapse the biofilm, and then maintain the space so it can't redevelop. So we need to move from trial and error to diagnose and treat. And then finally, why do we need to do that? Because wounds are increasing faster than we're healing them. So if a boat's taking on water faster than you can bail it, that is the definition of a crisis, okay? That ship's going to sink, and I think we're going to sink if we don't change how we approach the wound and get a little bit innovative. So I'd say don't confuse the comorbidities with the cause. The cause is biofilm. Important you treat the diabetes and all the other comorbidities. We're good at that. So you don't have to stop anything you're doing. But what I would add is the idea that chronic wounds are chronic infections, that we're going to do multiple concurrent things to collapse that biofilm and get control of the wound. And I'll illustrate that with the last patient. This is a non-healing surgical wound. Now, there's definitely some acute components to this. It's pretty red. But it's a diabetic with poor perfusion, and this has fallen apart in 2 weeks. So is that a chronic wound? Hasn't made it 30 days. But we waited about 10 seconds, okay, and then we got after it. We removed all the connective tissue, the tendon that was involved. I know it was biofilm because there was soft and diseased bone, so we nipped that away. And in 8 weeks, we had a granular wound bed that we could put scaffolds and cells and cytokines and other proactive things to get it closed. So what I tell you is time is tissue. So waiting that magic 30 days before you start treating antimicrobially is, well, I mean, when you say, why wait, there's absolutely no reason to delay treatment. Thank you.